Let us learn how to help a lady presenting with nipple discharge. We dedicate this lecture to our great teacher, Professor Ellie Hughes, Chief of Cardiac Breast Unit at the University of Wales College of Medicine, who advanced our knowledge in this subject. Nipple discharge is defined as a spontaneous efflux of fluid from the nipple, excluding physiological function of milk discharge during puerperium and lactation. It is an uncommon condition with which a lady presents to a breast clinic. 95% of cases happen to be of benign etiology. However, we should remember 4S, that is, if discharge is spontaneously occurring, if it is serous or sanguineous, that is blood related, if it is emanating from single milk duct, it is considered significant and pathological. We should assess the entire mammary gland and axilla as in any patient presenting with breast problem. Please remember that 5 to 10% of all patients may have a malignant cause for nipple discharge. The considerations to be given, whether it is physiological or due to some underlying pathology, whether it is emanating from single duct or from multiple ducts, whether it is occurring unilaterally or from both nipples, whether it is occurring spontaneously or only on pressure or palpation of the mammary gland, whether it is associated with an underlying inflammation of the major milk ducts, or if it is associated with a lump in the breast. The types of nipple discharge are listed on this table. A blood-related discharge can happen due to hyperplastic condition of the milk duct or a papilloma, ductectasia. Pregnancy may be associated with blood discharge, and in pregnancy it is considered physiological. Ductal carcinoma, both invasive type as well as in situ DCIS, can lead to blood-related discharge. Serous or watery discharge can occur in patients with hyperplasia of the mammary duct epithelium, duct hyperplasia, or ductectasia. A colored discharge is often seen in patients with ductectasia or some patients with breast cysts. Milk discharge is of course physiological during lactation. However, it can be pathological, and then it is called galactorrhea. Please remember, galactorrhea is defined as presence of copious amount of milk emanating from multiple ducts bilaterally, spontaneously in a non-lactating lady. Galactorrhea can be due to prolactin secreting lesions, either from the pituitary or some ectopic secretion of prolactin hormone, and number of drugs are listed as the cause for increased prolactin secretion and hence galactorrhea. Drugs such as methyl-dopa, oral contraceptive pills, and phenothiazines all can lead to galactorrhea. Various types of discharges are shown on this slide. On our left, we have a lady presenting with blood discharge from a single duct. Then we have clear discharge in the middle. Toothpaste-like creamy white discharge is typically seen in patients with ductectasia. Serous discharge from again a single duct, typical of a duct papilloma or ductal hyperplasia, or sometimes ductal cancer, is shown on this side, and yellowish pus-like discharge due to associated inflammation of the milk ducts, a condition called periductal mastitis. We should arrange the following investigations: triple assessment in the form of thorough clinical history and examination, followed by breast imaging, and if a lesion is found, its histological confirmation by a core biopsy. High resolution ultrasound is recommended to delineate any abnormality of the underlying ducts, such as dilatation of the ducts deep to the areola, which is often seen in as many as 75% of the lesions, and it has very high accuracy to the tune of 85% or more. Mammography is recommended for patients presenting above age 35. MRI may be considered suitable for patients who have blood discharge and in whom there is no abnormality seen on ultrasound or mammography. Cytology of the nipple discharge has low sensitivity to the tune of only 45 to 55% and is currently not recommended. Investigations such as ductography, ductoscopy, and fluorescence in situ hybridization are all described in the literature but have very little value in the management of a patient. Hence, they are not routinely carried out. The usefulness of nipple discharge cytology to predict breast cancer was evaluated in a recent meta-analysis. Of 286 articles screened, 12 articles were selected, including information on 1,476 patients. The meta-analysis results suggested a pooled sensitivity of 63%, which is significant statistically. The specificity was 95%, and a likelihood ratio for a positive result were 12.35, indicating that the possibility of breast cancer is 12 times higher with an abnormal cytology compared to not having breast cancer. The likelihood ratio with the negative cytology is very low, 0.39, once again demonstrating the ability of the negative cytology to rule out breast cancer. The overall diagnostic odds ratio is 31.88, which is very high with a statistically significant result. So, this meta-analysis suggests that we should be evaluating cytological examination of nipple discharge in women presenting with blood or serous discharge and get it evaluated by an experienced cytopathologist. Management begins by identifying the underlying lesion. For a patient presenting with galactorrhea, try to eliminate any mechanical stimulation, stop or change the medication if that is the underlying cause, measure the serum prolactin level, and if it is elevated, try to identify its source in the form of a pituitary lesion by high resolution MRI or CT scan of the sella turcica. Reassurance is helpful in majority of these patients. A lady presenting with colored opalescent discharge again needs to be reassured. Major duct excision, removing about an inch or 2.5 centimeter of the major ducts till we find the dilated ducts, may be helpful if patient has profuse discharge which is socially embarrassing. Treatment for patients with blood or blood-related serous or watery discharge is undertaken in the form of microdocectomy if blood is emanating from a single milk duct, or if lady is young, below age 35, and major milk duct excision, again removing a segment of 5 centimeter of major ducts if she is above 35 and has completed her family. An ultrasound guided mammotome excision can also be performed in selective patients. If you are not sure about the bloody nature of the discharge, you apply a white gauze piece and then look at the color that it changes to dark brown Coca-Cola color that is typically seen in patients who present with blood discharge. Blood discharge or blood-related discharges are often seen in patients who have hyperplastic ductal epithelium in the form of either a solitary duct papilloma or sometimes multiple papillomas, ductal carcinoma, which could both be in situ or invasive cancers, and sometimes in patients who have dilatation of the duct, a condition called ductectasia. Risk of cancer in patient presenting with blood discharge is directly related to the age of the patient. So, in patients below the age of 40, the risk is indeed very low, in the tune of about 3%. When we come to age group of 40 to 60 years of age, we find that about 10% of all blood discharges can be related to cancer. And in patients above age 60, about 30 to 32% of patients may have underlying cancer. Let us talk a bit about common conditions. Intraduct papilloma, which is the commonest cause of blood-related discharge in a lady. It's a benign tumor arising from the epithelium of the mammary ducts. It has a typical stalk and a fibrovascular core covered by papillary epithelium. And as the papilloma grows, its stalk may undergo torsion and may break, and this may lead to blood discharge from the nipple. On operation, we find papilloma looking with a papillary surface in the major milk duct under the nipple. And on a histological examination, we find fibrovascular core covered by papillary epithelium. On operation of the major milk ducts, we find a papilloma with a dilated duct as shown in this area. Histopathological examination reveals epithelial fronts supported by a fibrovascular stroma, and there can be multiple papillomata present along a milk duct. The term papillomatosis is applied for presence of 5 or more clearly separated papillomata in single or multiple milk ducts. These lesions are associated with an increased probability of bilaterality, presence of peripheral location of lesions, palpable lesions, and increased risk of cancer conversion with a relative risk of about 3. A unique type of papillomatosis is described in young girls called juvenile papillomatosis, also called Swiss cheese disease of the breast. This occurs in young girls with the mean age of presentation being 23 years. Lesions can be multiple, often palpable in upper outer quadrant. There is family history of breast cancer in a large majority of these ladies, and microscopically they comprise multiple papillomata with or without presence of atypia, apocrine cysts, sclerosing adenosis, and extensive ductal hyperplasia. There is increased risk of recurrence of these lesions after surgery and increased risk of cancer conversion in about 10% of ladies. The treatment comprises excision of the lesion and regular follow-up. The management of patient presenting with blood-related discharge is presented on this slide. Below the age of 30, a thorough clinical examination followed by cytology of the discharge and imaging by ultrasound may suffice, as most of these patients happen to be benign causes of blood discharge. However, in age group above 30, one has to be more careful and choose to do microdocectomy, removing a segment of about 5 centimeters of the milk duct from the nipple. So the management principles are as follows. If a lady is between age 30 and 45 years, surgery is recommended if there is family history of breast or ovarian cancer, if she is very much worried, or if there is nipple retraction. In women above the age of 45, where cancer risk is certainly high, we should carry out a major mammary duct excision, removing a 5 centimeter segment of major milk ducts from the nipple, or till we find dilated ducts, because this operation proves to be both diagnostic or therapeutic. It is also able to detect a condition called multiple papillomatosis, which is a risk factor for cancer. In women who present with non-bloody nipple discharge, especially if it is purulent, toothpaste-like, or colored discharge, we need to appreciate 2 important causes, that is periductal mastitis and duct ectasia. We should send the pus either from the ducts or from underlying subaerular abscess for culturing both aerobic as well as anaerobic bacteria. Cytology of the discharge can also be obtained. Imaging of the major milk ducts with high resolution ultrasound is very helpful in delineating the underlying pathology. Antibiotics are recommended in the form of either erythromycin with tinidazole or metronidazole, because there is a mixed flora of staphylococcus and anaerobic bacteria like fusobacteria and bacteroides. If there is a subareolar abscess, you should aspirate the pus and send it for culture and sensitivity. Limited drainage should be undertaken, and once the inflammation has subsided after 2 to 3 weeks of antibiotic course, we can then carry out a major milk duct excision. Ductectasia and periductal mastitis complex were first described by Hagginson, who gave the name ductectasia for a condition where there was dilatation of the ducts. It is often associated with inflammation around the ducts, a condition called periductal mastitis, which is often associated with fibrosis around the major ducts. It is often bilateral. The age group of presentation for ductectasia is between age 40 to 60, whereas periductal mastitis presents in younger age group between 18 to 48 years of age. Presenting features can be thick, creamy, or rarely bloody discharge from the nipple, non-cyclical mastalgia, mostly confined to the areola and central part of the breast. Patient may have recurrent episodes of subareolar abscess or sepsis. Sometimes an abscess bursts at the edge of the areola, resulting in milk duct fistula or mammary duct fistula. Due to fibrosis of the ducts and surrounding tissue, the nipple undergoes retraction, and there can be eczema of the nipple areola complex. Smoking has been considered an important risk factor, especially in Western women. Obesity, diabetes, nipple piercing, and people of black race all have been listed as risk factor for ductectasia and periductal mastitis. Its pathogenesis is relatively poorly understood. However, it is thought that there is dilatation of the duct due to loss of elastic tissue around the ducts, either due to hormonal changes or due to obstruction of the duct or due to some inflammation and fibrosis. There's a theory that there is keratin plug and squamous debris collects inside the duct, leading to duct dilatation. Ductectasia typically presents with toothpaste-like material coming from the discharge. On histological examination, you find a dilated duct with very little inflammation around it. Under a high-resolution ultrasound, we identify a dilated duct which is more than 3 mm in diameter across. Periductal mastitis is thought to be autoimmune in nature, resulting in chronic inflammation and deposition of mononuclear lymphocytes and plasma cells around the milk ducts, resulting in inflammation. Sometimes bacterial infection supervenes and subareolar abscess or inflammatory mass forms. The abscess may burst open, resulting in mammary duct fistula. The age group of presentation is relatively young, between age 18 to 48 years. Patient may present with typical purulent nipple discharge and a fish mouth-like retraction. This is transverse slit-like retraction or fish mouth retraction, as it is often called. Incidentally, this lady had an episode of subareolar abscess which burst open at this point, resulting in milk duct or mammary duct fistula. Under the microscope, you find inflammatory changes and fibrosis around the ducts. On higher power, we identify these mononuclear lymphocytes and plasma cells. Hence, another name for this disease is plasma cell mastitis. The management consists of aspiration of any pus, if present, under ultrasound guidance, and send the fluid for culture and sensitivity examination. If there is suspicion of tuberculosis, as in Asian community, one cause of non-lactation mastitis is tubercular mastitis. So we should also send this pus fluid for gene expert. Antibiotics are commenced in the form of anti-staphylococcal antibiotic along with anti-anaerobic cover with metronidazole or tinidazole for 2 to 3 weeks. If lady is smoking, encourage her to stop smoking. Surgical treatment is then offered 2 to 3 weeks later after subsidence of acute inflammatory features, which is in the form of a milk duct excision, which is indicated if there is profuse nipple discharge, blood-related discharge, recurrent subareolar abscess, persistent mammary duct fistula, and correction of any nipple retraction. In patient like this, where there was a milk duct fistula, we also performed removal of the fistulous tract in the form of fistulectomy. So the operation of major mammary duct excision was first described by John Hatfield in 1960, which consists of removal of 3 to 5 centimeter of the major ducts from the nipple. So we remove a segment of 3 to 5 centimeter of the major ducts, which are shown here as blue ducts. Its indication is listed on this slide: blood-related discharge, ductectasia or copious non-bloody discharge, and periductal mastitis. Initially, Dr. John Hatfield had suggested that we should remove about 1 to 1.5 inch of the major ducts. However, later authors like Dixon have suggested removal of a smaller segment of only 1 to 2 centimeter of the ductal cone, because the inflammation is confined only to the terminal part of the ducts and not in deeper part of the duct. For patients presenting with blood discharge, we should remove a segment of 5 centimeter length from the nipple, because papillomas are often located up to 5 centimeter from the nipple. The operation can be carried out under local anesthesia or general anesthesia. A circumareolar incision for 1/3 to 1/4 width of the areolar circumference is made, and ductal cone is dissected without raising an areolar flap. So we dissect the major ducts shown here with a right angle forceps, and then clamps are applied like towel clip cross clamps to dissect the major ductal system, which is then dissected off and removed. The nipple end of the ductal cone is marked by a suture to orient the specimen for the pathologist. Any terminal part of the lactiferous sinuses are then paired carefully by a dissecting scissor by inverting the areola. The incision is closed with a running continuous absorbable monofilament subcuticular suture with a suction drain. And this is the cosmetic appearance seen about 6 months from the operation. Microdocectomy is recommended for women presenting with single duct discharge, such as this young lady presented with pus discharge coming from the single duct, and she also had recurrent attacks of subareolar abscess formation. So we identified the dilated duct with a fine cannula, injected a drop of methylene blue to delineate this duct, and then dissected this duct. You can see the blue cannula and the blue stained milk duct, which was dissected up to length of 5 centimeter and then removed along with this. The wound is then closed with a running subcuticular absorbable suture, such as monocryl polyglycoperon suture, and this is the final cosmetic appearance about 6 months from the operation. The complications of milk duct excision are listed on this slide. They occur due to denervation or devascularization of the nipple areola complex, presenting in the form of necrosis of the nipple or nipple areola complex and loss of nipple sensation. And for obvious reasons, the lady has inability to breastfeed as the milk ducts are severed. Some patients may suffer from late re-retraction of the nipple even after correction of the retraction deformity during operation.
Some patients keep suffering from recurrent episodes of subareolar sepsis due to presence of a residual milk duct or part of an abscess cavity wall.
In summary, nipple discharge is often physiological due to pregnancy or breastfeeding, and it can continue for many years after cessation of the breastfeeding. However, some patients may present with pathological discharge due to papilloma, ductectasia, or periductal mastitis. And rarely, ductal carcinoma can be a cause of nipple discharge. The final message is triple assessment should be carried out to rule out underlying cancer. Microducectomy is recommended for single duct discharge, and major duct excision is recommended for patients presenting with multiple ductal discharge or who have blood or serous discharge. Thank you.